So next we have Dr. Shane Mathew, who's a senior veterinary consultant at Chaitanya Eye Hospital, Tiruvalla. He'll be talking to us on current approach to retinal vein occlusions.
Good afternoon to all. I think it's a repetition of the same talk in the same conference. I would like to reduce it or probably simplify it further. So what makes retinal venous occlusion a little different is because I call them as the Tandoni of retinal diseases because they don't follow any rules. You keep injecting, the patient may do well. Keep injecting, the patient may not do well. A BRVO may need more injections. A CRVO may not need this many injections. So there are no rules in this. But let's see what rules I do practice in my clinic and how I have changed managing these diseases over the past 15 years because we have a lot new armamentarium with us to make it a much better disease to treat with. I still remember while I was an MBBS student and I attended one of this conference with my mom and one of the senior veterinary surgeons saying, if you have a CRVO, send it to your enemy. And that is how we are because it is about sudden loss of vision, transient blurring of vision, or rarely retrobulbar pulsations. The take-home message is please look into the visual acuity of the patient, check for RAPD. Maybe that's a first sign of conversion to an ischemic venous occlusion. Look into the intraocular pressure as well as the location of the occlusion. It's very easy to diagnose a retinal venous occlusion. It is right there. But please look into the location. Hemicentral retinal vein occlusion like this one here follows the same pattern as that of a central retinal venous occlusion. So the follow-up should be like as that of a central venous occlusion. Sometimes the occlusion will be at the far periphery and you might find on a cursory fundus evaluation. You don't need to treat this patient at all. If it develops a neovascularization, then we need to treat it with laser. This is an impending RVO. We need to know this disease. It's called a venous stasis retinopathy, a lighter version of a furious RVO. But we need to know, not for the eye, but a systemic comorbidity might be lingering around in this patient. This patient had acute myeloid leukemia, which was found out after having seen this fundus picture. Sometimes a normal looking fundus. This is when actually multicolor imaging comes into play. Nearly normal looking fundus. Multicolor images clearly shows me the sclerosed veins in the inferior quadrant, telling me that this patient had an old RVO. So it's very important to do a systemic workup because most of these disorders are associated with a lot of systemic diseases. You can't write up all this investigation for every patient. So you need to divide the patients into two. Patients with young RVOs, patients with old RVOs. Less than 50, young RVO, more than 50, older RVO. And bilateral disease, I put it in the younger forms because better prognosis, uncommon etiologies are associated with young RVOs, lesser treatment burden, and better reparative process. Whereas old patients with RVO, think about an asymptomatic cerebrovascular and cardiovascular disease associated with it. So please send it to an internist for risk analysis for stroke and cardiac events. All patients should undergo a routine blood, RBS, lipid profile, and BP monitoring, probably a 24-hour BP monitoring. But I would like to draw your attention to triglyceride levels. Studies have clearly shown increased triglyceride level has a 10-fold increase in CRVO occurrence. Hemoglobin, increase in hemoglobin. This part of the world, this is relatively common now. A subclinical hypothyroidism, normal T3, T4 values, but a little elevated TSH level. Normally we would miss this. And also hyperhomocystinemia. So please look into these as well while you deal with the case of an RVO. It's important to stratify or divide the RVOs into a less severe variety called a non-ischemic variety, better vision, no RAPD, to a more severe form, an ischemic RVO with worse vision, RAPD, and ERG B-wave abnormalities. So why is it important to risk stratify them? It's because we need to see all these patients would need multiple treatment sessions, long duration of follow-up. So we need to reduce the treatment session and also reduce the follow-up. How do we do that? That is only by risk stratifying them. And one of the most important things is to look for the ischemic conversion. In that, Ideally, initial stage of the disease, you can't do an angiogram, but once the edema has subsided, maybe after a couple of injections, or in the natural course, after a couple of months, or maybe 1 or 2 months, or even 3 months, you can do a wide field angiogram. Wide field angiogram or ultra wide field angiogram helps us in showing us the peripheral capillary non-perfusion area, which is a biomarker for worsening disease. Now, studies have shown that the ischemic index is nothing but the area of capillary dropout to the area of perfusion. And if that is less than 10, these are the patients who will do well with macular edema treatment. And if you see more than 75 disc diameters of capillary non-perfusion, so 75 dd corresponds to, if you divide this fundus picture into 4 equal halves, 1 half. If you see more than that, you know that there is a good chance of neovascular development. So it is a good idea to do an angiogram. Probably one area where I would not hesitate in doing an angiogram is in this. After 3 to 4 months of post-CRVU, I would definitely do an angiogram to get these many information so that I can follow up on a personalized basis. So the next thing you look for is a collateral formation. Whenever the patient comes into your clinic, look for a collateral. So this is a BRVO with the last picture showing a collateral there. So when you see a collateral, now I know the repair is starting. The disease is slowing down and may need lesser follow-up visits and injections. So sometimes you see a retinal capillary macroaneurysm like this here, and that may be the source of macular edema in these cases. A focal laser to that may save the day for treating macular edema. OCT angiogram helps us in finding out macular ischemia and also a mid-peripheral ischemia. But I would say OCTA cannot replace a ultra wide field fundus fluorescent angiography because you cannot get images of that far periphery as for now in commercially available machines. And macular edema is the main culprit, what we treat normally. And OCT is by far the best investigative modality in detecting macular edema in this eyes. But anyway, in the start of the talk, I said it's a tandoni. So prognostic biomarkers has got little role here, but some of the biomarkers. So initially you do an OCT, you need to know whether there's macular edema or not, you start treating. But how to prognosticate, how to follow up, you repeat an OCT by around 3 to 4 months after you give injections. And then when you see that there is a residual central retinal thickness, if there is increase in cyst size or percentage of drill, then you know that this patient is not going to do well. And also ischemic indices such as hyperreflective inner retinal layers, PAM or a drill, these are all poor prognostic biomarkers, and these are the patients we may stop injecting at that point and then probably re-inject only if the visual acuity is decreasing further because of edema. So when not to stop treating, if the visual acuity is increasing, continue giving monthly injection because that is the best. But here is the news. Retained study, 4-year data told us that 50% of the eyes still need a treatment after 4 years of continued treatment. So we are looking at a very, very, very chronic disease. Now, once you decide to stop your anti-VEGF, look at the blue letters there. Once you stop anti-VEGF, that is the time to sit back and follow up the patient closely because of the VEGF upsurge, patient can have neovascularization. So once you stop treating, kindly follow the patient closely for 3 to 4 months for that. So there are ways, I'm just quickly going through. So this is one important point. See, look for re-occlusion. So once you need to understand that once there is an RVO, there is also a chance that a re-RVO can occur in the same patient. Look at this patient. Initially, the patient had an RVO. We treated well, middle slide, showing that things are settling down. 4 months later, patient has a re-occlusion. So once you see a re-occlusion, then what do? That is the time when you have to revisit the systemic status of the patient. And the patient may not regain a re-occlusion vision, and there is a high risk for neovascularization. Neovascularization, the standard treatment is retinal photocoagulation, even though anti-VEGF has a role and can continue, but I would still feel the treatment of choice is peripheral retinal laser photocoagulation. And neovascularization, the risk is more in the first year, so kindly follow this patient up closely during the first year. So that's where we are at the end of the talk, and a close follow-up with a risk stratification can reduce the number of injections and also reduce the number of follow-up. Here we have a chronic disease, so please take care looking into the selective systemic evaluation and also trying to find out what systemic disease the patient has. Thank you very much for your patient listening.
Thank you, sir, for that very updated and interesting talk. So, in